This lecture addresses some GI topics that show up not only on step 1, but also on the Pediatrics Core Clerkship Shelf Exam, as well as step 2. Hypertrophic pyloric stenosis entails stenosis, which means a tube or passage that was opened or normal, it got narrowed later on. Hypertrophy and also hyperplasia is how it got narrowed. The tissue thickened up and narrowed the lumen, and it's the pylorus that got narrowed. Remember, the pylorus is the opening from the stomach into the duodenum. Hypertrophic pyloric stenosis is just a little earlier in the digestive tract than where duodenal atresia can happen. While the vomiting in duodenal atresia is bilious, hypertrophic pyloric stenosis presents with vomiting that does not have bile in it. Also, while the bilious vomiting of duodenal atresia presents in the first day or two of life, the hypertrophy of the pylorus causing stenosis takes 2 to 6 weeks of life to develop. Via this vomit, the neonate loses a lot of gastric acid, which is hydrochloric acid. So they lose acid and chloride. So we get both a metabolic alkalosis and hypochloremia. We'll explain how, by the kidney trying to compensate for volume loss, we end up also losing potassium, giving a hypokalemic, hypochloremic metabolic alkalosis. This same metabolic disturbance happens in bulimia nervosa as well as purging type anorexia nervosa. It's all about vomiting hydrochloric acid and the collecting tubules trying to compensate for the volume loss. In hypertrophic pyloric stenosis, on ultrasound we can see the pylorus is thickened by hypertrophy and also lengthened. Hyperplasia is also happening, so we have both bigger cells, hypertrophy, and more cells, hyperplasia. We are taught that you can palpate in the epigastric region a mass shaped like an olive. Some clinicians may tell you that that would only happen if it's gotten so far that the weeks-old infant is about to die. We're also taught that the peristaltic waves may be visible to the naked eye. As you know, one of the drugs we use to treat chlamydia is azithromycin. I guess we could also use doxycycline. Drugs that end in thromycin are macrolides. So, azithromycin is a macrolide we use for chlamydia. Now, macrolides have GI effects. On the one hand, they are motilin receptor agonists that can be used to stimulate intestinal peristalsis. But they can also cause GI motility issues as an adverse effect. And probably related to that is that hypertrophic pyloric stenosis, the thing that we're talking about now, it's associated with exposure to macrolides. Now, vomiting, in which we lose stomach acid, can cause metabolic alkalosis. Alkalemia will mean the arterial pH is above 7.45. The reason for the blood being too basic is that there is too much bicarbonate. Quantitatively, the plasma bicarb concentration will be above 28. Now, patients with metabolic alkalosis may hypoventilate to compensate using their respiratory system. The idea is to keep more acid around in the form of carbon dioxide. Thus, PCO2 will be on the high side, so up towards 44. Again, pH above 7.45, that's what let us know that it was an alkalosis. And then bicarbonate above 28 let us know the reason for the alkalosis was metabolic. Now, to try to get the pH down closer to normal, in other words, to compensate, it's hypoventilation that will push the carbon dioxide partial pressure up towards 44. Since the acid we are vomiting is hydrochloric, it should sound reasonable that the metabolic alkalosis we will see will also be hypochloremic. Loss of volume from the vomiting can provoke another compensatory response. Aldosterone activity can increase. I think of aldosterone as doing three things with ions, plus one more thing. It pulls sodium back into the blood, and it pushes out protons and potassium. The plus one thing is that water follows the sodium back into the blood. So aldosterone can help retain water by reclaiming sodium and thus keep the blood volume from dropping as low as it would have. But when it does this, it's at the expense of potassium. So hypokalemia makes sense by this analysis. I guess there's a Japanese dude named Kawasaki who played at some point for the Cubs. In some interview, he says something goofy like, a monkey never cramps. The idea being that eating bananas, since they're potassium rich, prevents muscle cramps. In any case, you have to know for step one that hypokalemia can present with muscle cramps. Hypokalemia can also present with arrhythmias, which should make sense also. Phases 1, 2, 3, and 4 of the myocardial action potential involve potassium. Maybe I can say most importantly, phase 3, rapid repolarization, and maybe second most important is phase 1, initial repolarization. Potassium flow is also key for the pacemaker action potential, both phases 3 and 4. The more dramatic one, I guess, is pacemaker action potential phase 3, that is repolarization. On EKG, hypokalemia would show flattened T waves. Now, do you remember what electrical event T waves represent? It is ventricular repolarization. What is the treatment for a patient with hypertrophic pyloric stenosis? It is a pyloromyotomy. That's pyloro for the pylorus, myo for muscle, and tomy for cutting or incision. I think it's named Ramstedt after the physician who did one in 1911 or 1912. Anyway, surgical incision of pyloric muscles is what we're doing. However, before you do this surgery, you have to correct any electrolyte imbalance, and we talked about the electrolyte imbalances. So that would be a step 2 type of question. Okay, let's tie it all up. In hypertrophic pyloric stenosis, ultrasound shows a pylorus that is both thickened and lengthened. They love talking about the visible peristaltic waves and the palpable olive-shaped mass. Presentation occurs later than that of duodenal atresia. Here it's 2 to 6 weeks after the baby is born. The vomiting here is non-bilious. Hypertrophic pyloric stenosis is associated with exposure to macrolides, which end in thromycin, including azithromycin, which you recall from treatment of chlamydia. And you cover gonorrhea with ceftriaxone, unless for some reason they've already tested negative for gonorrhea. Erythromycin can be used to stimulate intestinal peristalsis, but macrolides are known to cause GI motility issues. For fun, let's recall that macrolides bind to the 23S rRNA of the 50S subunit. Hypertrophic pyloric stenosis entails non-bilious projectile vomiting. This means metabolic alkalosis, so pH is higher than 7.45, that's the alkalosis part, and bicarbonate is higher than 28, that's the metabolic part of the alkalosis. The chloride will be low, under 95, because we've lost the HCl that came from the parietal cells. And respiratory compensation for the alkalosis is done by increasing the PCO2. Overall, we get a hypokalemic, hypochloremic, metabolic alkalosis. It's in the attempt to compensate for volume loss that aldosterone gears up, which costs us potassium. So that level drops to under 3.5. This is how aldosterone works. It increases reabsorption of sodium in the collecting tubule, and water follows that sodium. That was the whole idea here, to keep the blood volume from getting super low. In exchange, the principal cells secrete potassium, and the alpha intercalated cells secrete protons. The hypokalemia part of hypokalemic hypochloremic metabolic alkalosis may mean muscle cramps, as well as issues with cardiac action potentials and conduction. EKG can show both U waves and flattened T waves. While, yes, the surgical correction of hypertrophic pyloric stenosis is this Ramstedt pyloromyotomy, the first thing that needs to happen is electrolyte levels need to be checked and any imbalances corrected before that causes a problem. Okay, that's it for this one.